Thank you, everybody, for joining today. I can see the attendee room is just filling up now. Welcome to episode 3 of our specialist-led educational series. Today I'm joined by Dr. Clinton Colaco, infectious diseases physician based in Sydney, but also consulting in a number of other locations and doing some fantastic work via telehealth. Just before I hand over to Dr. Colaco, we want to make this session obviously as interactive as possible. What you'll see down the bottom on your Zoom options, there's an option for Q&A. Please post any questions that you might have during the webinar in the Q&A section, and after Dr. Colaco's presentation, we'll come back and go through those questions. Thank you very much. I'll hand over to Dr. Colaco.
Thanks, Liam. Thanks for the introduction, and thanks for Extra for giving me this platform. So, hi everyone. As Liam mentioned, I'm an infectious disease physician. I'm very much a general infectious disease physician that works across the hospital as well as the outpatient setting. And so, one of the key topics that I think is something that we can all do as clinicians is look at some of the antibiotic allergies that patients have and how this is a changing landscape. And funnily enough, we actually one of my colleagues presented on this today, early in our departmental meeting at Westmead, and I've included a couple of his slides as well that might be useful for some really contemporary data. So this is me. I basically work in quite a number of places. Physically today, I'm in Rockhampton, where I do a bit of private work in the private hospitals here. I do quite a lot of research work through the University of Sydney and University of Queensland, and teach quite a few students as a result of that. I have a lot of different appointments in different places. So I work as a postgraduate fellow in advanced therapeutics at Westmead Hospital, basically coming up with alternatives to antibiotics, particularly in the space of really resistant gram-negative organisms that are carbapenemase producing organisms. I work as a staff specialist in the acute medical unit at Canberra Hospital, doing acute medicine work or general medicine type work. Basically, when patients are admitted in the first 48 hours, they come in under our team before they either are sent home or to another team for ongoing care. And a lot of VMO hospital appointments as well as consulting clinics. So penicillin allergy, why do we care? The penicillin allergy, I guess, label is associated with a lot of different key problems, and some of this includes suboptimal or broader spectrum antibiotic use than is actually intended or required. Higher rates of C. difficile infection. I've had a couple of patients in the last couple of weeks that have had C. difficile, and I've had quite a number of patients over the last few years that have had terrible C. diff, such that they needed consideration or received fecal transplant. So this is something we really want to avoid, and I think this is a real miss if we are causing this. There's quite a lot of multi-resistant organisms out there, and I was sort of alluding to some of my research-based work. And really, there's only a few antibiotics that can treat a lot of these conditions, and so we need to preserve predominantly our tablets for you guys as GPs or in primary care, so that you can give patients effective antibiotics without the need to get them into a hospital-based setting. Our penicillin allergy has been known to cause lengthened hospital lengths of stays, more hospital readmission rates, an increased risk of or rates of surgical site infections. We can't use the standard antibiotics, and therefore they're getting maybe suboptimal choices. And there's a lot of unplanned intensive care admissions resulting. So some of the new teachings in this space, 3 main things to come across in the last 5 to 7 years, is that 50% of people with penicillin allergies may not be allergic after 5 years. This allergy label or penicillin allergy may wane over time, which is something new to most people. However, if you really look back and you think about it, how many people might have inadvertently given penicillin to one of their patients? I know the common thing in the hospital setting is we see someone's allergic to amoxil, but they've got a really bad chest infection or they're immunosuppressed, and someone gives them tazocin, because that's what we do. We give people tazocin, and we forget that there's piperacillin, which is a type of penicillin in all of that. Nowadays, there is a lot of, I guess, alert tools to say this person may have a penicillin allergy and to reconsider that choice. But this invariably happens. Many people have reported penicillin allergies, but are not true allergies, and this could be an example. Some people write down or tell other nurses or pharmacists or clinicians, "Oh, look, I'm allergic to penicillin. What's the allergy? I have nausea and vomiting. I get a bit of diarrhea." That's not really an allergy. That might be an adverse drug reaction, but really should be distinctly labeled as something else. And last but not least is the cross-reactivity. So it's thought that, well, sometimes in literature, I think it's reported up to 10%, but realistically these days, 1 to 2% of patients with a confirmed penicillin allergy may have a cephalosporin allergy. And it's important to note this because people that are allergic to penicillin may be allergic to cefalexin because of a similar chemical structure, and I'll talk about that shortly. Now, this is the therapeutic guidelines, which I should add is actually going to receive an update in the next 7 to 9 days when it's presented at a national conference for us in Canberra next week. But as you can probably see, I mean, most of these are hospital-based conditions, but every main sort of system where antibiotics may be required requires a penicillin to be involved. So whether that be febrile neutropenia, cholangitis, hospital-acquired pneumonias, or surgical site infections, you name it, there is a penicillin-based antibiotic there. So this is really important. Not to mention that urinary tract infections, which I haven't included, which we both commonly treat, would also have cross-reactivity occurs between beta-lactams that share a similar R side chain group. And here, this table sort of demonstrates that anything in the same group is considered very similar. So this is penicillins with the same R1 side chain. And long story short, to put into simple terms, someone that is allergic to amoxil should be allergic to Keflex. You can't and you shouldn't really give them Keflex if that's the case. But if for some reason you've felt strongly about their amoxil allergy, given them Keflex and they've passed the test, theoretically speaking, they were probably never really allergic to amoxil, or they've outgrown that allergy. And this is something that we can tell these days. There are other penicillins here that may be very similar, or maybe slightly different. And so some people will be able to tolerate flucloxacillin when they have an amoxicillin allergy because their R side chains are a little bit different. And this is the cross-reactivity that they were talking about. But when you look at it, there's a much lower cross-reactivity with some of the other antibiotics. So none with the monobactams, which is not orally available. It's talking about aztreonam. And then with meropenem or carbapenems, there's a less than 1% risk of cross-reaction. So this is why traditionally you would see some people that have penicillin and cephalosporin allergies that get admitted to a hospital and go straight to a carbapenem because of a lack of cross-reactivity. So there's things that are not a true allergy that I've alluded to, like nausea, vomiting, diarrhea, renal impairment. Some of these are very much expected adverse reactions from certain antibiotics, particularly with renal impairment and trimethoprim use. So it doesn't mean you have to avoid that antibiotic completely. It's just that you might want to monitor their renal function a bit more closely. There is hypersensitivity reactions that are immune-mediated, whether they be IgE or IgG or T-cell mediated. And these are some of the starting to become a bit more concerning reactions that we see, ranging from urticaria to blood abnormalities or dyscrasias to really severe syndromes such as DRESS or SJS. And then there's the infusion-related reactions, which occurs in all sorts of settings, not just antibiotics, but typically the one that I see in my practice is vancomycin, where they get this urticaria or flushing or angioedema type reaction. You reduce the rate of vancomycin by 50%, and basically they tolerate it again. But you see this with monoclonal antibodies that you might be supervising or know patients on or have patients on, or other therapies. And basically you just slow things down and it should resolve. And this is again a mast cell driven or basophil driven non-IgE mediated response or anaphylactoid response. So everything comes full circle, and in this case, it involves really taking a good history. And I think that this is the single most important thing to really get on top of this crisis, I guess, of antibiotic allergy. And it's important to know which drug, what was the reaction, was a non-allergic reaction, was it a mild allergic reaction like a rash, or a severe one like anaphylaxis or TENS or SJS or DRESS? When was the reaction? The key marker is 5 years, and I'll explain why, but it's important to really gather when it was, what kind of treatment they had, and really give them the options. Did you get an EpiPen? Did you get some steroids? Did you require to go to ICU or emergency? When did it occur? Because this really changes the risk profile. This probably doesn't project very well, but just in terms of the colors, anything that's green is not considered to be significant. For example, a childhood exanthem or delayed hypersensitivity beyond 24 hours after starting an antibiotic, or a really distant reaction 10 years ago. But we start to get worried if we see a bit of a rash, if we see a bit of throat tightness or lung respiratory compromise or swelling or urticaria. These are bad signs, and even worse signs when we see the blood dyscrasias and other biochemical abnormalities. So traditionally, allergy testing revolved around sending a patient to an immunologist, and they would get skin prick testing, and basically that involves just pricking the epidermal layer with a lancet, and then checking to see if there's any reaction after a period of time, and therefore that's considered a positive result. And whilst very easy to perform in the right setting, it's really, really hard to get these patients into these clinics these days. I've heard of public hospital waiting list times of in excess of 2 years in certain places. Some places don't have a service, and even some private settings have a 6-month waiting list, because as you can imagine, some of this is quite intensive on nursing staff as well as medical staff. And so therefore there was a need to look at another option. And this is where this tool came about. And it's called PenFast. It's available on MD Calc if you want to look at it in more detail, or look at the literature behind it. But it was basically designed by a very clever infectious diseases professor in Melbourne by the name of Jason Trebbiano. And it basically revolves around a scoring system where you gain points for when something occurred. So if the reaction was 5 years or less, you would get 0 points. If you had no anaphylaxis, no angioedema, you get 0 points. If you had severe cutaneous reaction, you get 0. If you didn't get severe cutaneous reaction, you get 0. And if you didn't require treatment, you get 0 as well. So that would add up to 0, which is considered very low risk. If for some reason you required treatment for something, you might be a 1. If you decided to have a reaction in under 5 years, you'd get 2. So what we're looking at is patients that are very low risk or low risk that could be considered for some sort of testing, because really less than 5% means less than 5 out of 100 should have a true penicillin allergy. We don't feel like we should really be rocking the boat, I guess, for these moderate risk or high risk, and maybe this is where traditional allergy testing may come into this space. So we felt over the years that it should be suitable for these sort of patients to undergo or undertake direct oral challenge. And so this is what some protocols used to look like in the early or pre-COVID days. And essentially, it involved the use of a penicillin at a fraction of the actual intended dose. So a lot of the times it looked like 1/10 of the dose, and then watching the patient for 30 minutes, then giving the full dose, and then watching the patient further. For patients, as I mentioned, with higher risk, this would not be really looked at and referred on to a drug allergy specialist. So again, another assessment for low risk patients. And another way to do it was a 2-dose oral challenge, which is basically a fraction of the dose, the full dose, and that would pass. Some people do a direct oral challenge, which is just the same dose again in a control monitored environment, and then check to see if they've had any allergies. So I thought I might just talk about a couple of cases that I had. So this is Mr. TW. So basically, he's a 78-year-old guy that presented to one of the private hospitals here in Rockhampton. He had a Klebsiella pneumoniae, a bloodstream infection secondary to urosepsis in the setting of chronic myeloid leukemia. He received 5 days of Keftrax and then had Bactrim, which is probably fine. But I noted that he had a penicillin allergy when he was referred to me, and he mentioned someone in Brisbane, a diseases guy. He said a diseases guy like you had some interest in testing a theory. And I said to him, you know, what happened? Why didn't you go ahead with it? And he said, oh, they ran out of time there, and they said consider it when you go back to Rockhampton. And so he was interested, and this was at like 8 or 9 p.m. at night. And he said, look, I want to do it, but I want to get clearance from my boss. And so the boss said yes. And so he actually went ahead the next morning in the hospital to do this direct oral challenge. So in this sense, we did it with a 250 milligram dose of penicillin, which in his case was amoxicillin. We monitored him at 0, 30, and 60 minutes, at 30 and 60 with OBS specifically, and he had no adverse reactions. I walked down from my clinic to see him at about 3 hours, and he didn't have a reaction. So the outcome was positive. He was delabeled. He could use penicillin in the future. I sent a letter to his GP to consider referral for his wife, and also say that he could safely use penicillins in the future. And that was that. The next one is a bit more of a tricky case. So this lady was admitted in the public hospital in Canberra. She was only 36, but unfortunately had quite a rocky disease course in terms of that. She had a formation of a ileal conduit in the setting of excision of a suprapubic catheter, which was for this odd syndrome called Fowler's syndrome, where she had functional bladder outlet obstruction. And so she was a sitting duck for chronic UTIs or recurrent UTIs. But really, her main problem was that she was just getting purulent discharge just outside of the tract site. And so it was swabbed and it found to have non-multi-resistant MRSA. And look, this is quite alarming, but it's not uncommon as to what we might experience once a month. And you could imagine, like this, I'm sure it does your head in, but it equally does our head in, because we always get referred these kind of cases saying, pick an antibiotic. And essentially, this patient would come into hospital and she would either get no antibiotics or she would get vancomycin and gentamicin. So she had actually 0 options available from an oral point of view, at least at this stage. So I gave her clindamycin. It wasn't listed in this list, but it was listed somewhere. And I sort of said to her, look, you actually are sensitive to this drug. It would be handy to keep you out of hospital if we swapped it in the community. So let's give it a go. And so we gave it a go. In her case, I gave her 150 milligrams as a test dose. It was a bit of a guesswork, but that is the lowest dose you can possibly give. And she didn't have any adverse reaction whilst she was there, but I heard later on that that I gave her C. diff, which was really sad, because I do know that clindamycin has quite a high chance of causing C. diff if taken in excess or for long term. But one dose, single dose, gave her C. diff, which is really sad. So these are a couple more slides from Westmead that were presented today about different sort of settings that we are doing this in the inpatient setting. And essentially, we're looking to liaise with teams to look at some of these patients to either delabel inside of the hospital setting or bring them to a follow-up clinic to do this. And essentially, it's about giving patients information, whether to empower patients to see that this is something really handy, maybe not so much for their acute care presentation, but for a follow-up presentation, or to allow you guys as GPs more access to antibiotics to give patients. And so the way in which we do it again at Westmead is very similar. We give a 250 milligram stat dose, and we monitor the patient for 2 hours rather than the 1 hour. There's not a lot of data as to why we need to monitor them for that long. So this sort of thing, when I do it, in my rooms personally, I sort of introduce or say hello to the patient when they walk in, give them the dose, and then check on them between patients or as the next patient leaves to see how they're going. And everything seems to go okay, but I'm always ready with the EpiPens if need be. Some of the recent outcomes of what we've got is we've done 19 rounds at Westmead Hospital and directly delabeled 14 patients. 20 patients were suitable for oral challenge. 11 patients received oral challenge, 9 of which were successful. 19 referred to outpatient allergy clinics, and lots of patients given information regarding their antibiotic allergies. So some of the reasons that patients not receiving oral challenge may be that they were being discharged that day, and I heard of similar experiences with the Queensland-based patients. You know, there's lots of bed pressures to get patients out, and sometimes these sort of things get planned for the daylight hours and then get put back to the afternoon shift and then don't get done at all. Some patients do decline. They are, you know, very skeptical about doing this. I do appreciate that. But then other patients are really, really appreciative. And I do know right now there's a patient that's currently admitted that I delabeled, and she's come back with a different reason. And, you know, she's again another CML patient or leukemia patient. And now we can actually use Tazocin or Augmentin on a rather than giving her meropenem all the time. And that can mean that she can probably stay out of hospital if and when she gets another urine infection, because I think she's getting resistant to the other agents like trimethoprim, Cipro, and nitrofurantoin. And other patients are also then referred to the GP, so yourselves. But you know, you may not get some of this education about the value of doing some of this or how easy it is to do something like this. So some of the reflections that we got from our patients is that it's tricky for patients from a non-English speaking background. It's hard to get all their records. It's hard to make them change their minds when they're told they're penicillin allergic all their lives. And yeah, quite a lot of things going on that make things a bit of a barrier. This is a cancer center in Eastern Sydney that also does direct oral challenge. So they're a private cancer center. And again, they've picked certain patients in certain ways. They've got certain exclusion criteria, for example, particularly around pregnancy and on steroids and hemodynamically unstable. But to be honest, a lot of the studies are coming out in some of these settings, particularly in pregnancy, where there's also, again, a limited option or amount of or type of antibiotics that we can use safely. And so, again, it's something that we keep on looking into because these are the populations that really benefit the most, including those that are immunocompromised, as I've alluded to. So this is what we do. We can give any of these sort of antibiotics, and we can always look at alternative options. I've learned recently that we can give clavulanic if we're concerned about it specifically. But like once you start to get to a little bit more niche stuff, and it goes beyond either a bit of an amoxil challenge or a Keflex challenge or a sulfur-based challenge, you know, I think it's where you start to involve specialists like myself or an immunologist if they're keen to really look at this sort of thing. And I guess where this is coming full circle is most people know of desensitization as the automatic answer to when someone has an allergy. But really, desensitization is incredibly time intensive. You know, basically you need to give a dose every hour that's graded, increasing. You know, you need a nurse to draw up the medication, you need a cannula. It's not something that you can do in great amounts. So yeah, so I think that this holds very true. This was published last year, and really delabeling is becoming one of our most important ventures. So this was presented at one of the major conferences in Australia that's run by Jason Trebbiano. And look, I think it's really important that we don't label penicillin allergies anymore unless they've had a true reaction to penicillin. And I must say, I've only ever called an allergy once probably in the last few years, true. But I think it's important that we really reaffirm people's allergies. And it doesn't go for just antibiotics. I think it goes across the spectrum of therapeutics. And yeah, so don't label allergies when they're side effects. Don't, dismiss cephalosporins if you can use them. You know, people do get EBV rashes, particularly the young children, and so they may maybe put onto amoxil, so that may not be a reason not to give that again. And yeah, there's quite a few different things to consider there. So these are my references, and I'm more than happy to take any questions either about this or about some of the ways in which we can work together. But just as a final summary note, I like to sort of see patients in all different settings, and so some of these patients are now referred to my outpatient clinics. But some of the initial discussions whether someone may want to proceed can very easily be taken or performed via video telehealth means, because all it comes down to is a nice, robust discussion of what it looks like and why it's important. And I think that that's something that, as a acute care and infectious disease physician, I can really answer well. So thank you. Any questions?
Fantastic. And yeah, look, thank you very much for that wonderful presentation, Dr. Colaco. So guys, if you are looking to ask any questions, Dr. Clinton, the Q&A button is down the bottom. You'll click on that and then you can pop any questions. If you did want to raise your hand, we can obviously also open up your microphone and let you ask your question in person if that's the way you'd like to go. There is a great question that's started to come through. So Dr. Clinton, it's you can also see the Q&A and I'll
Yes.
obviously
Yeah, I
moderate.
can see it there. So thanks, Yeleni. So throat swab for recurrent throat pain. Patient has heavy growth of normal flora. Need to start antibiotic. Look, I think tonsillitis and pharyngitis is something that you guys will see quite commonly. And I think, it's good to do the throat swabs. You're really looking for group A strep, you're looking for strep pneumoniae. If it's present, it vindicates your use of phenoxymethylpenicillin 500 milligrams twice a day. But if it's normal mouth flora, it's probably a viral cause for why they're getting all these symptoms. And I always say more tests is not necessarily such a bad thing, particularly if someone else is paying for it. So, you can do a respiratory viral swab as well as bacterial swab at the same time through a lot of the private labs. And at least you can get an answer within 24 hours if you do it. So I'd probably hold off and sort of see how they go. But if you see pus, I think it's a different equation altogether. And we had a patient actually here last week in Rockhampton that had pus, and it was sent in by his GP. And look, there was real concerns, for trismus, he could barely open his mouth, and he had a CT neck that showed an abscess there, but he got a bit of Dex, and he got some antibiotics and he got discharged within 24 hours. So, sometimes it's the pus really. I think that would be my reason to give them intravenous or tablets for that setting, but otherwise I wouldn't really be giving them oral antibiotics unless I can see some real concerns there.
Fantastic. And Dr. Clinton, I actually had a question. I know that you were talking around some of the different ways you were treating patients with telehealth and so forth. If the doctors do have a patient that sort of fits the criteria today and they were looking to send that, how do you sort of manage those patients in terms of obviously the geographies?
Yeah, so geography wise, I'd be very interested to know where everyone is coming from today, and if you could put that in the chat or in the Q&A, that would be great. But to be honest, look, it just depends. I see patients in literally every setting you can imagine. So I've had GPs, for example, that visit nursing homes that say, look, I really need something for urine infections. Can you see this patient? They're stuck in the nursing home. And I say, yeah, fine. And so we do this novel thing where when they're there, we sort of make it a convenient time and call each other on a WhatsApp video. At least I can see the patient and build a slightly higher item number, but also gives the patient the care that they need. So that's a really important tool that all clinicians can use in this video telehealth era. But otherwise, I have a lot of rooms throughout Sydney. Particularly, I have 8 in Sydney. I have 1 in Gosford. I have 1 in Rockhampton. I have 1 in Canberra. So those are my physical places. Yeah, that's kind of where. But otherwise, I think that this is one of the main things where video telehealth is really helpful, because what it really involves is at least coming to an assessment or coming to a plan that this is a necessary or useful thing, and then planning accordingly. One of the places that I try and do this as well, just so they have the added benefit of extra support if things go wrong, is private emergency care centers. And so they could, and with partnerships that I have, particularly in Sydney, but this can be done anywhere. We can organize for them to go into these sort of places. But I do know a lot of GP settings are well set up with crash trolleys in case things go wrong, and so this could so easily be done in that setting and being observed in that way. Yeah.
Excellent. And I guess just in summary, obviously, as a result of the guys jumping on the call, is there sort of a sense that you'd like to see sort of being done differently going forward?
Yeah, look, I think it's really important to consider, when we need to use an antibiotic, to use the right antibiotic. And if you don't, and if your first or second choice of antibiotic's not there, then you probably need to ask yourself why. And that might be based on the pathology, but it might be based on the allergy. And I think, it's important to do these sort of things, particularly pre-winter and post-winter, because when winter time comes, it's probably a little bit too late, because this is when you might need an Augmentin or Amoxil or Keflex, and you can't really use it then. And so then you're giving them things that they may not want or need, like clindamycin or Bactrim, and then maybe causing a new problem. So I think this is part of preventative healthcare planning. I know a few of the GPs that I've spoken to, they've mentioned that they want to incorporate something like this into a care plan, to just sort of say, when was your allergy? How long was it ago? Did it require treatment? Did it require hospitalization? Is this something you'd like to revisit? And then that sort of becomes a nice way to say, hey, they actually are interested in doing some of this. When we've done some stats, particularly in urgent care settings, almost 1 patient a day has some sort of a antibiotic allergy. And so, that's not a small insignificant number, but it's something that can be done. I've seen rates of 1 in 10, for example, in terms of all presentations. So this is something, really should be done for the younger patients that have these allergies, so that when they, get older and need to go to hospital or need antibiotics, we have a wide range of antibiotics to give. There's not many antibiotics in the pipeline, unfortunately. So once patients, for example, get Pseudomonas infections, we've got 1 tablet and that's it. We lose that tablet, we've got nothing else. And so similar story with some of the other conditions as well.
Excellent. Well, look, I'd like to thank Dr. Colaco for joining us today. Just before we jump off the call, just to update you, Dr. Colaco is an example of one of the many, many specialists that are working with Rextro to obviously engage further with primary care. That can be via Zoom calls like this, or you can actually set up sessions for face-to-face environments where people will come out to your clinic and obviously deliver programs. The great thing is you can restrict those slots around the different sections. So if you're looking to increase or looking for additional work around measuring objectives, for example, you can obviously tailor those sections just for that. But look, once again, thank you very much to Dr. Colaco. Thank you very much to everybody joining the call, and we'll have another one of these sessions very, very soon.
Thanks, Liam. And I'll just sort of end here. If you want to send a referral, drclinton@colaco.com.au is my website. All the details are there. I use all the main electronic messaging systems, so feel free to reach out. Thank you.
Thanks.
Bye for now.